Welcome to the Terminology Leading Practice 23. My name is Jim Case, and I am the Chief Terminologist at SNOMED International, and I will be moderating today's sessions. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter, and on-site attendees, please use the microphone provided in the room. I'm now pleased to introduce Olga Endrich from Inselspital University Hospital Bern, who will be presenting INFRA INFectionRadar with SNOMED CT from a national framework to patient-centered visibility of sepsis in the EHR. Olga, please go ahead.
Thank you very much, and thank you for the possibility to present our work here in Atlanta. I'm Olga Endrich. I'm working in Insel Group. It's University Hospital of Bern. I'm responsible for medical coding, so DRG reimbursement, and I'm product line manager, product line medicine in Insel Group. Inselspital Bern is actually the oldest company in Switzerland. It was founded 650 years before by Anna Seiler, the founder of the hospital, and is still operating under the same name. And it might be old, but it's not old-fashioned. So it's a lot of strategies put in the digitalization of medicine and moving forward international operability and standards. So we have this organization established 5 years ago. The name is Insel Data Science Center. So actually a hub organization which enables our university hospital use data for clinical, not clinical research, data science, usage for data for medical solutions, quality improvement, and data-driven support of management of the clinic process. And we started in 2017 with establishing of clinical data warehouse. So first, really simply data collection, pulling data out of different medical sources like laboratory system, ICU, ER, and putting it into the data lake and then processing it to the MySQL database and enabling in first-line research with real-world data. So actually our first use case was in 2017 due to introduction of the new coding guidelines. So maybe you're familiar with the CADIGA organization, which promotes coding guidelines and clinical management guidelines for kidney disease, kidney injury, and kidney insufficiency. So the problem we had was that our lab system provides just absolute numbers for lab results, and for clinicians, it's difficult to calculate relative differences in different lab values, which are actually the base for the diagnosis for kidney injury. So we started with the idea to use the data of the clinical data warehouse to retrieve this information and develop the algorithm. So it's a rule-based algorithm using SQL microbatches statement, and allowed us to apply different status of kidney disease. So actually at the end, we use the real-world data and can retrieve patient-related data for individual level of kidney disease. So this first data pipeline consists of 4 pieces. First, data pipeline of our laboratory result, laboratory information system, data warehouse, algorithm proceeding, and then providing a diagnosis. So we have both implementation like a real, near real time information for alerting clinicians and retrieving information really very quickly. So it's milliseconds. And another implementation is the backwards recalculation of the highest level of the kidney injury during a certain hospitalization, usage for coding and better documentation. So after 5 years of usage of this algorithm with really better data quality and increase of correctly coded ICD-10 diagnosis in our data warehouse. The advantage of having this diagnosis is firstly, of course, also to providing better information for research, labeling diagnosis, and having the consistent and reliable information behind this diagnosis. So currently we know that each ICD-coded kidney disease diagnosis is based on KDIGO guidelines. And this is a big difference like before we started. So started with 2017 with this data pipeline, we continue to work. And in 2018, it was the second use case based on the outbreak of vancomycin-resistant enterococci. And it was one of the biggest outbreaks in Europe. And this data pipeline was actually used also for retrieval of information of vancomycin resistant enterococci information out of lab, also identifying the patients and enhancing the cohorting and isolation of patients in our hospital. So it was really very useful to have this information, and the clinical data warehouse was the only place in our hospital which allowed us to put all different data sources in one platform and retrieve information out of one place. Then the COVID came, and of course it was like the second use case, and as I mentioned before, it was the only possibility to have all information in one place. So it was our workhorse during pandemic to use this data pipeline to management of COVID, identification of wards with patients, identification of patients, providing clinician with a working list. So it was like really the only instrument which helps us to have this management of COVID in our hospital. Also reporting of data to governmental bodies, so all this communication, it was based on this algorithm. Then came respiratory and gastro surveillance, CAUTI, CLABSI, so maybe you are familiar with this, is sort of quality instrument to assign a number of infections during the hospitalization by catheter, and it was also possible using the same data platform information. Adding multi-drug resistant organisms using data out of microbiology lab with resistancy. So all these cases added up, and at the end we had a family of ecosystem which was built around of INFECT as a concept. So now the big change we are facing now is the go live, the EPIC system in March 24. So a lot of preparation of data ongoing now. The common map of all these projects for data in e-surveillance ecosystem is built here. So around of concept, we have different dimensions. We have microbiology, medication, procedures, symptoms, management, demographics, vital sites. We also put the terminologies we are using now. So it's SNOMED, LOINC, ICT, ICD-10. So all this family together build our ecosystem concept, build it in this SQL database now. So, and now INFRA. INFRA is the next step. INFRA INFectionRadar is a project which started in March 2023. It's a SPHN demonstrator call. I will come back to what SPHN is. It's a national project which is supposed to demonstrate the added value of the infrastructure of clinical data warehouse and usage of elements of data-driven personalized health research. SPHN is a program supported by Swiss government, and Swiss Personalized Health Network is a project which started 5 years ago, funded by Swiss National Scientific Center, and so actually it's governmental money which supports two goals. First, building of the infrastructure, supporting university hospitals So we have 5 in Switzerland to build this infrastructure, to build clinical data warehouse, and also to build central data hub, which allowed us exchange data. And the second goal is to enable projects to use this infrastructure and show the value of this infrastructure. So the first goal is actually to build it and to enable research with routinely collected health data. SPHN provides not only money, it provides also guidelines and framework for best usage of this data, framework and ecosystem which allowed us exchange data over different organizations and hospitals. Infra specific is project which also has many goals. First is to build this interoperability and system permeability system. So what's the problem we are facing now is this disconnection between EHR, clinical data warehouse, and SPHN collaboration environment. So we are using data which were collected out of clinical applications. They are unstructured in a data lake, and some of them are structured, but not all of them. And only by the last step, while providing data to SPHN, we put semantic meaning to this data. So it's actually on the top of the pyramid. And what we want to do to enable a building of semantic layer in the EHR itself, so to support this interoperability from down to top and from top to down. Project Infra has also a use case. It's not only infrastructure, it's also to show how we can generate more value. We want to develop a visualization tool, so to demonstrate different dimensions of individual infection manifestation and support clinician by prevention and treatment of surgical site infections. So the focus is to develop this tool, which is comprehensive and helps clinician to anticipate the possible trajectory of infection development. So we have great project team, data scientists, data engineers, clinicians, and semantic experts, which work together on this project, contributing different parts. So it's really a great collaboration possibility. We also have partners in University Hospital of Geneva. They have a huge expertise in semantic and terminology. So I think it's great opportunity to collaborate in Switzerland and develop projects together. So the aims and objectives are to build on our e-surveillance ecosystem to enable semantic meaning binding in this ecosystem. For example, semantic definition of surgical site infection, a definition of sepsis, development and integration of relevant concepts, and reusage of data for national projects and using SPHN standards. So, and of course, like the end, we have blueprint of this dynamic visualization tool, which, if it's work, can show the whole data development evolution from the EHR to visualization tool and research. So why infection, why sepsis? Even if Switzerland is a rich country, we have, of course, problem with sepsis. It's still a huge burden and a cause of mortality. And during pandemic, it was a problem. So of course, every country had to struggle with sepsis. So Switzerland as well. Burn is here blue, dark blue. It's you might ask yourself why do we have more sepsis cases? Is it higher incidence in Switzerland, or what's going on? And I think we have two aspects here. First, yes, of course, we have geographical speciality in our countries. We have a lot of mountains, so not everywhere we have like the same population. But another aspect is, and I think it's also important to know, this incidence is based on ICD-10 codes, and ICD-10 coding is it's not so standardized. Even we have coding guidelines, but still, I think in burn we are more sensitive by coding, and this leads to these higher incidence numbers. So we conducted research and compared the ICD coding to underlying clinical definition out of a study, and it was pure coverage. So abstraction of sepsis by ICD coding is not sufficient. So we miss maybe 1/3 of cases if we only rely on ICD coding. Another problem is that if you compare ICD code today and 10 years ago, it's completely different definition of this clinical build. So sepsis, third definition was published in 2017, and if you compare the same clinical definition, it's completely different if you take sepsis 1 to third definition of the disease itself. So concepts change over time, and we know it's not enough just to take ICD code. We have to move more in detail. So, but how to represent reality? So we are going back to the like atomic level of sepsis. It contains not only diagnosis, it contains also the underlying clinical vitals, finding, time series. So how to represent this reality, and being sure that we can depict the right cases, and be sure that our specificity is also high. So what we are doing now, we are starting today with our EHR, which is based actually on discharge letter. So information pulled together in one letter. You have narrative, you have text, you have lab, you have underlying differential diagnosis. And moving towards EPIC, our goal is to decompose this one discharge letter in pieces. So we have different domains, for example, problem diagnosis, vitals, imaging, microbiology, and procedure. And all of these information pieces will be mapped to the to terminologies and structure information, for example, SNOMED Link, ICD-10. So this ongoing work is now in some status. We can actually complete some tasks, for example, for mapping of diagnosis, almost done mapping of lab values, and for example, work in progress for mapping of microorganisms document types. So the idea is to create cross-reference data set which allowed us to combine data from the older system, so old clinical data warehouse, and the new system in EPIC. So now this cross-referencing data integration process is ongoing. We got also support from our colleagues, and a lot of people are working on this project together. So our project team, EPIC, and of course, our department, our project, and IDC itself. So huge work to be done, but yes, I think we can move forward and have some results now. The idea is to be ready to go live in March 24. So to have mapping of the most important domains there, so we can use the data from the first data after go live. And yes. Semantic transparency. So we have also German terminology service provided our vendor. So we are able also to text mining, to do text mining and assign SNOMED concepts and German specific SNOMED version. So actually it's a problem, but I think Germany is doing a lot of effort to keep the progress going. So data representation, SPHN provides a lot of concepts. So it's actually a framework we can use for also for defining our concepts. We use resource description framework RDF, which actually described each concept in consisting blocks. For example, we can, with one concept, it's generic enough, so it can help us to build concepts which are extensible, they are interchangeable, and allowed us also exchange of data with different hospitals. For example, here, concept of diagnosis has a lot of attributes, so has some definition, which terminology we have to use, but still we have also freedom to use another terminology. So we are, if we find that some terminology is not good enough or need some extension or additional information, they can also use different terminologies to explain the same concept. So for example, we have concept with higher complexity. We, for example, FiO2 to describe the clinical finding relevant for sepsis. And especially for sepsis, we are trying to develop a new compound subscore concept, because now we have a concept for sepsis, which is just a simple concept with one number. I think it's not enough, so we can to move like one level deeper and develop a concept of 6 subscores, which allowed us to represent each organ insufficiency itself. So for this simple concept and scores, we develop a data map, and moving forward to map all this data out of clinical data warehouse and simultaneously cross-reference into the future EPIC concepts. For example, we started with vitals. It's a problem. We have 86 different items for blood pressure coming out of different clinical systems. And the challenge here is to find a map which is generic enough to build all these concepts without loss of information. We also provided the first analysis of the Loink concept for lab results. It was interesting to see the gaps. It was also interesting to see the evolution of the Loink codes in our system, because it was like the first approach to make some evolution map and to see how data evolves. Also to treat issues with the quality problems, deprecated codes. The same for assessment for different scales. So we started to map, for example, vitals for the different SOFA scores using different concepts available in the system. And for example, organ failure due to sepsis and decomposes in the different subscores. We have also did this work with our DDD algorithm, comparing the algorithm generated codes with electronic discharge letters. And we found out that a lot of information is lost, so the clinician actually didn't document this diagnosis appropriately. So we have a gap between text mining diagnosis and DDD retrieved generated diagnosis. Also interesting, so comparing different representation possibilities, for example, comparing SNOMED and Loink SOFA score concepts, which are different. but it's a good possibility to combine both sides to better depict the SOFA score concept. Here, a list of vitals we need to map. And the problem is that if we go further, we have to make a decision about which interoperability rule is more important for us. Is it FHIR? Is it EPIC system? Is it SPHN? Is it low and SNOMED? So a lot of consideration have to be made, and to choose the best way for further development and interoperability guidelines. So we propose a vital valid composite score for SOFA, which consists with all values, all test assessment we need to have, also require point of time, respect all inclusion conditions. So, and thinking that if we have definition of such a concept, we can provide reliable information also for clinician, knowing that this concept is built on this data and we have no missing values. So this, the output of this assessment is valid. So this is the end product of our conceptual work. We have to provide it to SPHN. They also approve the concept and can implement it on the national level. If not, we can use it concept for our own purposes local. But the aim is, of course, to support the community in SPHN and to implement concepts which are useful for the whole Swiss landscape. So this is the end result we are proposing to SPHN, and if it will be approved, we can build the information, and this concept will be underlying RDF definition for data exchange. We have also visualization, first visualization tools we built on our data, and the last part to use the machine learning approach and Bayesian approach to build the different trajectories of the sepsis development are also available now. So we discovered 6 clusters and can also integrate this cluster in the visualization tool we are now developing. So, for example, depending on which underlying condition or the age the patient might likely to develop sepsis or infection post-operative. So this is the first preliminary visualization we have developed, and this is actually the underlying visualization idea we will use too. So this is the brief overview about our project. Thank you very much for your attention.
Thank you, Olga. We have time for 1 or 2 quick questions. Is there any in the audience? If not, thank you again. And with that, we will conclude this session. And this is the end of this session. And I think this is the end of the Expo. Yeah. So thank you all very much for attending, and safe travels home.